Today, a simple case of Marfan syndrome. Only thing is how to evaluate in an OP within 5 minutes. A 10-year-old boy came with aches and pains and generalized weakness. He looks very thin and a little bit tall. His limbs were just skin and bones and veins, no muscle mass at all. The look itself was suggestive. So, how to establish clinically that possibility and assess the complications within a short period. The first thing is the anthropometry, how to establish the growth and the pattern which is it suggestive of a Marfan syndrome. Any growth problem, whether it is underweight, short stature, tall stature, or you need to plot it in the growth chart. So this is the IAP growth chart for boys from 0 to 18. So this is the marking. His height is in the higher centile, somewhere around the 70th centile. And his weight, you see, it's a 3rd centile. Just take the height part only. The mid-parallel height is in the 25th centile, but his height is in the above 70th centile. One thing which you need to assess apart from this is the weight for height. And one more thing, weightage and height age. See, his height age is 11 years. He's having 10 years, but he's having a height needed for the 11-year-old child. Now take the weight. Weight is 20 kg only, and that is 3rd centile. Actually, what about his weightage? Weightage corresponds to 6 years and 1 month, 2 months. So weightage is on the lower side, extremely on the lower side. If you calculate the weight for height in the IAP thing, definitely significant wasting. So weightage on the lower side and heightage a little on the higher side. So that is the first thing which you do. Then you should check the general examination for all the features. What are the main things which are affected in the Marfan? It's the musculoskeletal features, because basically it's a disorder genetically transmitted, majority of the cases autosomal dominant. 25% of the cases it can be new mutation. So you don't know whether in this case a new mutation, we didn't do the genetic study, we have to do it. The maternal height is short, father is a little taller, almost normal, but here there can be a possibility of a de novo mutation. The musculoskeletal, due to the genetic disorder, fibrillin gene is the one involved. Involvement, apart from musculoskeletal, you need to assess the eyes and the cardiovascular and nervous system. In a short period, you have to assess. So what is seen here? This is a chest deformity. Majority of cases there will be chest deformity. In the front, it will be the pigeon chest deformity. Pes excavatum is a little on the lower side. Here, when you see the chest, very important, at this point itself, you can assess the cardiovascular. What do you expect in the cardiovascular? Most important is the aortic abnormalities. You can have an aortic root dilatation, aortic regurgitation, and one of the complications is aortic dissection. The second thing is the MVP with or without MR. So, these are the commonest of the involvement of the heart. Sometimes the tricuspid valve also can have the valve prolapse. So, now with the chest wall, what you need to check is the apex position and the force and the precordial hyperdynamicity, because these are the one things involved. Aortic regurgitation, hyperdynamic precordium. MR again hyperdynamic precordium. Apex may be displaced in both the volume overload of the LV situations. The other situations like JVP may not be that much important, that much involved. So in the cardiovascular examination, what you need to check at the wrist is the radial artery. The radial artery, most important, the pulse volume and the collapsing nature. So in this case, the radial artery pulse was normal volume. It was not abnormal. Right, rhythm, everything was normal. And the other thing is always check the other pulses also, because some of these situations, complications like dissections are common, where there can be an involvement of the subclavian and carotid and the other things. The abdominal diaphragm can be involved, so there can be a disparity in the volume of the other pulses. So all the peripheral pulses, volume, and if it is a collapsing pulse, BP also, because there can be a pulse difference, the difference between systole and diastole. So if there is a leaking evidence, AR evidence, other peripheral signs also. In this case, the volume of the pulse was normal. Simple things. This is a foot long and arachnodactyly, long fingers or fingers. See the hands, again long fingers. He's having prominent veins. There is in the wrist also, it's very skin and bone situation. This is one very important sign. This is thumb sign. Thumb sign, Steinberg sign is one of the signs. The thumb will jet out of the ulnar side when you hold it, when you make a fist. That is one of the very important signs, because there is a scoring system giving points for all these things. This is the wrist sign. You should be holding with the little finger. See, normal person cannot hold. This is a positive wrist sign. And this is the simplest of the thing. You look at the palate, it's a high arch palate. This is one. And what I should be checking was the eye. In this case, eye was normal. In the eye, what I should be looking for is the dislocation of the lens. In that situation, iridodonosis I can make. Ophthalmologist will send for the evaluation of the whole eye, where the cornea can be involved. There can be retinal involvement. One of the complications, retinal detachment. So, ophthalmologist's opinion was it was not involved. Lens was normal. So, is it against the Marfan? No. There can be the variations, the different mutations, different mild to severe variations. There are situations where the eyes are normal, no dislocation. Here is one very interesting thing. Apart from this thing, there can be other features of joint laxity. This is very evident. Again, when the fingers backwards is having significant joint laxity in the knee also. One very important finding here is on the knee, the prominent scars. So there are two more entities very closely related. Ehlers-Danlos syndrome, different types, and the cutis laxatica, where this fibrillin, the genes involvement, and other things which are elastic fibers, there can be difficulty in healing of the injuries, wounds, and papery scars can be there. Here also sometimes it's possible in the variety mutations. And what are the other things which I should be checking? In this case, cardiovascular system evaluation was done. Pulse was normal, BP was normal. Apex was a little shifted in the fifth space, but it was not forceful. No palpable thrill, no LPSH. JVP was normal, but on auscultation there was a click and murmur. What is more important in this case is aortic dilatation and the regurgitation, which are easily missed, because the aortic regurgitation is a diastolic murmur which is easily missed unless you carefully look for in the expiration with the disc well of the diaphragm of the stethoscope in the swooping forward position. So we auscultated for it. He didn't have an aortic regurgitation murmur, but he did have an systolic murmur and a click. So what should be the position of the examination? I said for the aortic regurgitation in the sitting position and swooping and with the diaphragm. But MVP, something called dynamic auscultation. You make him sit and stand. And what happens during the standing up from the sitting position? The click will be prominent and the late systolic murmur will be prominent. In this case, it was a significant systolic murmur was the, click was the. And the other thing is eye evaluation. It was normal in this case. So what are the investigation which we should be doing? There can be the involvement of the dural ectasia can be demonstrated by imaging, and confirmation is by genetic studies. In this case, it's an OP case. We are ready to do this thing. The whole purpose is to finish the clinical examination in a case of like this Marfan's.